This is yours. You're the captain, you're the master, you're the foreman, you're the general, you're the head. Don't give control of this to nobody.
Renal dialysis costs tens of thousands of dollars a year per patient, and as we just heard, the condition it treats, end-stage kidney disease, is commonly caused by diabetes. Now a group of Australian researchers has modelled whether a new class of drugs could stave off end-stage kidney disease, saving lives as well as money. The drugs are called sodium glucose cotransporter 2 inhibitors, or SGLTI2s for short, and they're a shift away from simply managing blood glucose, which is how diabetes is generally treated now. One of the people looking into this is Professor Jonathan Shaw, a Deputy Director at the Baker Heart and Diabetes Institute. Welcome, Jonathan.
Good afternoon.
Diabetes treatment, like we said, is usually about managing glucose, but these drugs work a little bit differently. What are they and what do they do?
Yeah, so this is a relatively new class of drug. We've been using it now for about 7 or 8 years. And whilst when we first started using them, we thought that they were just another option to manage the blood glucose. It turned out that when the trials started coming in, that in addition to lowering glucose, they had this profound effect on heart disease and on kidney disease, something that was quite unexpected, but certainly very welcome to see. And it really has changed the way that we think about what drugs to use for what people and what we might be able to achieve with these agents.
They still do manage your blood sugar though, don't they? So is there still a place for antihypertensive cholesterol-lowering drugs in people with diabetes?
Absolutely. These drugs don't replace other things. So it's really important to control blood pressure. It's really important to control cholesterol. It's very important to control blood sugar. But we're now seeing through mechanisms that, to be honest, we don't really understand. We're now seeing that these drugs have effects beyond all of those things and further reduce the risks, particularly of heart failure and also of kidney failure.
Right. So why do we need to be looking at drugs at all? I mean, couldn't we be doing more to just prevent people from getting diabetes in the first place with lifestyle interventions and those sorts of things?
We absolutely need to be doing that sort of thing. So there's just no doubt that that's a good thing to do, a valuable thing to do. But whatever we do in that space, we're always going to have people who, for whom it doesn't work, people who can't make the changes that are required. And, perhaps we've even seen this in the COVID vaccine space at the moment. If you don't back enough horses in the race, you can get stung when you run into problems or the expected limitations of any single strategy. So we certainly need to do both things. And the other thing about it is that diabetes prevention, and this really applies only to type 2 diabetes, but prevention of type 2 diabetes is a great investment in the future. But according to our modelling, it's an investment in the somewhat distant future. And that's because in the next 10 years, almost everybody who will develop kidney failure as a result of diabetes has already got diabetes. They've probably already had diabetes for several years now. So the dividends from diabetes prevention certainly won't apply to everybody and definitely are not going to apply, at least for kidney failure, for at least 10 or 15 years. And that's what our modelling showed us, and which we want to make an inroad into the increasing numbers of people ending up on dialysis and requiring kidney transplants. We have to do something else.
Right, so it's a diverse portfolio that you're looking at. So the other two, so you looked at a large lifestyle modification program for diabetes intervention, a sugar tax, and widespread use of these SGLT2Is among people with diabetes. What sort of results were you seeing at different time increments in your projections?
So what we found was, and this wasn't a surprise, but the drugs work quickly. Within a few years of getting increasing uptake in the numbers of drugs, we're starting to see 20-25% reductions in the numbers of people ending up on dialysis. Now, that's of course assuming that in the case that we did, we assumed that 50% or maybe even better 75% of people who are sort of heading down that track towards kidney problems were getting onto these medications and staying on them. Whether that happens in reality is another matter. We were modelling what would happen. When we looked at what would happen with the lifestyle intervention, whether that's a sort of a personal, individual-based lifestyle intervention or whether it's something like a tax on sugar-sweetened beverages, it took 10, 15 years before we started seeing a benefit. Now, what we also saw was that after the first 5 to 10 years of increasing benefits for the medication use, that started to plateau off as it was sort of somewhat overwhelmed by increasing numbers of people with diabetes. And so that really tells us that it has to be a package deal, that we need both components of this. We need to treat people who have diabetes, and we need to do everything that we can to prevent future people developing type 2 diabetes.
Because we are seeing an upward tick in the trajectory of diabetes incidence in Australia. What's the status of these drugs at the moment in terms of who they're approved for?
Well, at the moment, we have these approved, and it's just changed in the last few weeks. We're now seeing these approved for use in people with diabetes, with type 2 diabetes, and with already some degree of kidney dysfunction. Unfortunately, at this stage, that is not all backed up by Medicare. So for access to these drugs for Medicare at the moment, it's only possible for people whose blood sugar control is not good enough. And that really brings us to this sort of paradigm shift that we have. These are drugs that work for preventing kidney failure and also heart failure in people with diabetes, and they seem to do that irrespective of their overall blood sugar control. But at the moment, we're somewhat restricted. We can only use them in people whose blood sugar control isn't good enough. And that's sort of on the old paradigm of they're just for lowering blood sugar. Now we know they're just for a lot more than that.
Right. Watch this space. Professor Jonathan Shaw, thanks for joining us on the Health Report tonight.
Thank you.
Jonathan Shaw is Deputy Director, Clinical and Population Health at Melbourne's Baker Heart